Hello, everyone, and welcome to our 2024 Central Canada PKD Patient Forum. My name is Michelle Goodfellow, and I'm the Communications and Engagement Manager for the PKD Foundation of Canada, which is the only national organization solely dedicated to fighting PKD through research, education, advocacy, support, and awareness. This session is presented by nephrologist Navdeep Tangri with a patient story from Tatiana Walker. It was originally recorded in the opposite order, with Tatiana's story first and Dr. Tangri's presentation second, but we've rearranged the order of the sessions so that the nephrologist's presentation is first. So you may occasionally hear the speakers reference information that came from earlier or later in the presentation. This is Dr. Tangri's presentation.
First, my apologies to the audience. I still had the old time in my calendar for 2:30, and I was planning to be here for 2:30. So my apologies for that, and I'm really happy to be here. I'm a physician scientist at the University of Manitoba, so I spend 20% of my time in clinical care and 80% doing research. But the large majority of my clinical care actually is in polycystic kidney disease. So I developed an interest in looking after people with polycystic kidney disease a few years ago, and I see many patients with polycystic kidney disease, probably somewhere between 50 to 100, which is a lot for a disease that's not very common. Just hearing the end of Tatiana's comments, I think it's really important to not talk about those dreams at a young age, actually, from a physician perspective, to not say anything definitive, because I'm actually quite optimistic about the future. I think that the kind of medicines that we're developing today have the potential to not only change treatment for polycystic kidney disease, but for kidney disease in general. I mean, it's evolving rapidly. So, Tatiana, I would tell your son that the football player thing is still very much alive. I think it's all very open. And it also brings up another important point about when to discuss genetics with your children, right? Like I think that perhaps when they're older and you can have a more nuanced discussion might be better, but that's just my perspective. So I'm going to try to go over in the next 20, 30 minutes some big sort of common questions that come up from patients and families, and then I'll hopefully have some questions from you. Would you mind just enabling screen sharing for me? I think make me co-host, and then we're. Ah, perfect. That's working there. Great, thank you. So I hope you can see my first slide. Do you see that in presentation view?
Yes,
Perfect.
we can see
Great.
it.
Perfect. Great. So just some disclosures. I do a lot of scientific work, so I receive funding both from granting agencies and from pharmaceutical companies. And one of the companies which I have a small amount of funding from is Otsuka, the manufacturer of Genarc. So just I want to just be upfront with the audience about that. Always very important to have disclosures. So first, we have two kidneys, and two kidneys filter about 200 liters of blood daily to remove water and waste. But that's not all what the kidneys do. They also control blood pressure. They control all the salt and water balance in the blood, sodium, potassium, calcium. They make red blood cells. That's why you become anemic when you have kidney disease often. And they make active vitamin D. They activate vitamin D. So vitamin D, which comes from sunshine in our body, is not activated without kidneys. So all the sunshine in the world doesn't work if you don't have kidneys. What is autosomal dominant polycystic kidney disease? So it affects about 1 in 500 people, and about 1 out of 7 of those people have no family history. Healthy kidneys are about the size of a fist. So about 12 centimeters on average is about a healthy kidney, 10 to 12. Patients with polycystic kidney disease will typically have kidneys that are longer, so about 16 to 19 to 20, but they'll also be growing out in 3 dimensions. So if I think about the volume of a healthy kidney is about 150 milliliters on average, and a polycystic kidney can be up to a liter, liter and a half. So the volume can be quite large, and that's why we feel pain and discomfort. So the kidneys are made up of about a million nephrons, which are little filters. and that's why it's called nephrology. And what these cysts do is they actually directly compress on the nephrons. They get filled with fluid, they directly compress on the nephrons, and we begin to lose more and more of our kidney function. So my patients with polycystic kidney disease have some of these things. They have pain and discomfort, first of all, because from the cysts just mechanically putting pressure on the flanks. They can also have kidney stones. That's why we always drink a lot of water to prevent kidney stones. Bleeding and infection can happen in cysts. We can lose kidney function. We can have protein in the urine and have high blood pressures. That's what's happening inside the kidney. Unfortunately, accompanying this often is some valve issues in the heart, cysts in the livers and the lungs and the pancreas, diverticulosis, hernia, and the most important one, which is aneurysms in the brain. And sometimes we do an MRI to make sure that you don't have an aneurysm if you're a patient. If you're wondering why we do that, it's because we want to make sure that we're not missing any aneurysms. ADPKD is just sort of bad luck, right? It's just a genetic hit. And what you see is for a long, long time, the kidneys are growing and the GFR or creatinine is in the normal range. So you can get this sort of false set of reassurance that I don't have disease or I don't need to do anything about it. But actually, we want to stop this growth because once we get into this downward trajectory of kidney function, it's more difficult to stop. So we want to act sort of earlier on to extend the straight part of the line as long as possible. So let's talk about genetics. So first, we're made of billions of cells. Each cell has DNA. DNA codes RNA. RNA encodes protein. We have 30,000 genes, 2 sets of genes, 1 from each parent. There's like 3 trillion letters, and 1 mutation in PKD1 or PKD2. Those are the 2 more common genes can cause ADPKD. That means it's dominant. That means if your parents who have 2, both of your parents have 2 each, if you get even 1 of PKD1 or PKD2 from either parent, you get autosomal dominant disease, which is why it has a 50% inheritance. Okay, and this kind of shows there for an average person, it's a 50% chance if one of the 2 parents has it. Now, this is the part about why genetic mutations matter. So if you look here on this slide, it shows that if you have different genetic mutations, so ranging from the orange all the way out to the purple, you lose your kidney function faster. So people with PKD1, particularly ones with a truncating mutation, lose their kidney function starting in their 30s and 40s. And then the orange is PKD2. So there's sort of a spectrum of disease. There's 2 things that determine how fast you'll lose your kidney function. One is kidney size, and one is your genotype. And of course, there are other things that can make it go faster. And let's get through all of those in the next few slides and in the next few minutes. So the crazy thing, though, is genetics is not perfect, okay? Even if you have a truncating mutation, you can still get mild disease, and some people can still have minimal disease out to their 70s. So neither genetics nor kidney size explains the entire picture. 2 people with the same genetics, one can get kidney failure in their 40s, another one can get it in their 60s and 70s. 2 people with the same size of kidney, one can get kidney failure in their 40s, the other one in the 70s. So each one gives us part of the story, not the entire story. And often we're looking at not just that, we're also looking at blood pressure control. Did you have stones? Did you have any cyst ruptures? Did you have diabetes in addition to a polycystic kidney disease? So there's a number of things we try to look at and things we try to treat to prevent progression of kidney disease and to slow it down. Although MRI is the best assessment of disease risk, sort of, the larger the kidneys on MRI, this is somebody with 1A disease with a PKD1 mutation. So same mutation in these 2 people. This person has 1D. Look at the kidney size. Same genetics, but one person has massive kidneys, another person has fairly small kidneys. This person is very unlikely to progress. And which is why, if anybody has been on generic or they have family, friends who have been on generic, they would say that the doctor looked at kidney size before they made a decision about whether to prescribe generic or not. What about in families? So twins usually reach kidney failure within 2 years on average. And 2/3 of those with ADPKD reach kidney failure within 7 years. So we ask about family history. We ask, do you have family members who are polycystic? What age did they reach dialysis, if any age? Because it does help. However, there are differences. Not everybody fits. So I guess what I'm trying to say is that for 2/3 of people, the pattern will fit, but for about 1/3, it won't. Okay. So in fact, greater than 30% of families with greater than 5 affected members have two people who are more than 15 years apart. So like a big difference. So if it's a genetic disease and it's just genetics, why don't two people with the exact same family have kidney failure at exactly the same time? I think you'll see from the next few slides that it's obvious why. First, despite having the same genetics, we have different habits, different exposures, and different environment. We may have an other cause of kidney disease. We may get different treatments and different adherence to different treatments. And there might be other genetic factors that predispose to kidney disease, not just in the PKD gene. So first, smoking. Okay, so very clearly, if you smoke, your disease is going to go faster. Not only your PKD, any kidney disease, heart disease, stroke, vascular disease, it's all going to go faster. So if you smoke, probably the most important thing you do before considering any treatment is stopping smoking. Second thing is lifestyle. So maintaining a healthy weight. In this study called HALT PKD, of people with early stages of polycystic kidney disease, those who were overweight or obese had a 2 to 4 times higher rate of decline of kidney function. Okay, so it's important to maintain a healthy weight. It's important to exercise. I know many of us are in discomfort because of the cysts, but a healthy weight does protect against loss of kidney function and cyst expansion. It also protects against pain. The bigger patients were, the more pain they had. And it also makes sense because there's not just the weight of the cyst, but there's also total body weight that may be contributing to those same muscles. Then eating and dietary habits, so time-restricted feeding, fasting, intermittent fasting, ketosis, salt intake, protein intake, all these things have been studied. None have yet to be conclusively proven. So unfortunately, none of these is at a level enough where I can clearly recommend it and say that you should follow one of these diets. So what can I recommend? I think I should recommend that you should eat plenty of fruits and vegetables because that's clearly good for your kidneys and your heart. Eat high protein foods, make water your drink choice, and choose whole grain vegetables. Water. So we think about water. When we have a lot of salt and not enough water, when we're thirsty, our body has to concentrate the urine and our kidneys have to work harder. The principle behind water restriction and tolvaptan is to block the concentrating hormone or antidiuretic hormone, okay, which makes the kidneys work less. If you don't take GnRH, can taking more water do the same thing? So this is a study which looked at people with polycystic kidney disease who drank either 2.5 or 3 to 3.5 liters of water a day. It turns out there was really no difference in loss of kidney function or cyst growth in people who drank between 2.5 or about 3 to 3.5 liters of water a day. These were pretty low risk patients. And we didn't show that just drinking water alone outside of GnRH can completely protect your kidneys. However, there's no doubt in my mind that water intake reduces stone intake and reduces calorie intake. So it's probably not a bad idea. So no matter what your kidney size, drinking more water will prevent stones, and stones we know accelerate polycystic kidney disease. So we do want to drink water. The data on stones is quite bad. So 10 to 20% of patients will have a kidney stone. Those with stones often have larger cysts, bigger kidneys. And if you have a stone, you have faster decline in kidney function. Again, how do you avoid stones? Water intake. Avoid salt, avoid animal protein. Definitely don't take vitamin C. I actually recommend that people don't take any supplements because I think supplements often have ingredients that may are not tested to the same rigor as medications. And particularly some of them, if they contain vitamin C, even, which seems very benign. I mean, we're all told vitamin C is amazing, eat oranges and so on, and orange juice, but actually it can lead to kidney stones. So consider no supplements. People can have two kidney diseases. It's pretty rare to have PKD and another genetic disease like glomerulonephritis, lupus nephritis, FSGS, or this PKD1 tuberous sclerosis overlap syndrome. But it is common to have diabetes and ADPKD. In fact, I have a handful of patients who have both diabetes and ADPKD. And if you have both, your kidneys decline faster. You have bigger kidneys. You get earlier blood pressure, earlier hypertension, and we need to be doubly aggressive for treatment of both diseases. What about blood pressure? So this is crucial. In the HALT PKD study, patients were randomized to a blood pressure target of either 120 to 130 or 95 to 110. So when your doctor says, I want you to have a blood pressure around 100 to 110, this is why. Those who had the lower blood pressure did better. In fact, when you look at change in kidney function rate was slower in people, about 1% per year in kidney volume and kidney function in people who had a lower blood pressure. So low blood pressure is important. And the other thing we can do is tolvaptan. So tolvaptan, on average across all studies, lowers your rate of kidney function decline to about 2.5 per year if it's going at 3.5 to 4% per year. So about a 30% reduction in the loss of GFR. And that's why we recommend it for people who are at risk of losing kidney function rapidly. It's not a benign medication. Even though it causes 30% reduction in the loss of GFR, less pain and less stones, we have to pee a lot. Often 3 to 4 liters a day, getting up 2 to 3 times a night. It's costly. There's a monthly blood draw. There's about a 1 out of 20 risk of reversible liver injury. This has been much less. This has turned out to be actually 3 in 1,000 of any significant liver injury. So I can disclaimer that. And 2 to 4% increased risk of gout. None of my patients have gotten gout yet because most of our patients tend to stay quite healthy. So those are the pros and cons, and happy to answer more if anybody has questions about that or anything else in this presentation. High cholesterol, heart attacks still kill a lot of people with PKD. In fact, most people with PKD unfortunately die of heart disease. So I'm not sure that statins will prevent PKD or slow cyst growth, but statins do prevent heart disease. So if you have PKD and you're older than 40, definitely older than 50, you should certainly consider a statin. When it looks at safety in people with the trials of tolvaptan, people did quite okay if they had if they were on tolvaptan and a statin, and there was no additional liver damage. Just some thoughts on genetics again. We're learning a lot more. There may be patients with shared PKD, PKD1, PKD2 mutations. There may be diagenic PKD, which is cysts from other other relatives and so on. And then you can have different outcomes. And there may be another mechanism that's affecting, and we're still learning so much more about that it's not just simply knowing what gene you have. That's why we do imaging. That's why we ask about all of those questions. But nonetheless, it is still very much a genetic disease. The treatment is, the cure when it comes will likely be related to genetics. But before that comes, let's reshuffle the deck in your favor. Don't smoke, drink lots of water, be active, get a healthy body weight, really get tight blood pressure control, get a home blood pressure machine, focus on staying as tight as possible. Consider a statin if you have high cholesterol, and consider tolvaptan if your kidneys are very large and your physician and you discuss the risks and benefits together. I think nothing is benign. Almost all of these things, even if they seem like no-brainers, need to be a focus of a conversation. So talk to your doctor about everything you can do and stay very optimistic, because 10 years ago, we didn't have tolvaptan. 10 years from now, I think we'll have multiple treatments. There are so many things in the works for PKD, including silencing, RNA silencing genetic medicines, and other CRISPR-related therapies could come into play. So I'm excited about the future. And in addition, of course, I'm sure you've heard about animal transplantation for people who get kidney failure. Just lots of great stuff on the way. So I'll stop there, and happy to take questions.
Thank you so much, Dr. Tangri. We really appreciate, and I mentioned to the participants ahead of time that we had supplied you with a lot of questions, and I know we'll have some more questions here, but we really appreciate having access to your experience with PKD and being able to address some of these concerns that people have. So sorry, go ahead.
Yeah, I'm happy to answer the two questions that are in line. So first, regarding orange juice, please, a glass of orange juice is not the issue. It's supplements, because supplements really will have way more vitamin C than a regular diet has. So please continue to drink your glass of fresh orange juice. It's just don't take supplements. With regards to the information I presented, the genetic things I presented are all relevant for ADPKD, not for ARPKD. But if you have ARPKD, things about blood pressure control, cyst sort of drinking water, and staying a healthy lifestyle will still be relevant. But the genetic information, everything I presented, is only specific for ADPKD, which is the more common disease. And unfortunately, I don't treat a lot of ARPKD. So if you had questions about ARPKD, I'm probably not the best expert to answer. So go ahead. Okay. So how is all this knowledge? So what I would suggest, Jessica, is that PKD has become a bit of a specialized disease where it's probably best managed by kidney doctors who treat a lot of patients with PKD. There is a website, I think, where you can see where if there's a PKD clinic in your city. And I think I can speak on behalf of myself and most of my colleagues. None of us are ever offended if somebody takes a second opinion. So it may be, for example, let me just hypothetically throw one out there, that let's say your kidneys are not very large and you don't need generic and your blood pressure is really well controlled. In that case, maybe I would say everything is okay and see you next year. But I think if you're concerned, a second opinion is valid, and doctors who treat a lot of PKD may be more up to date on the newest treatments and the clinical trials and stuff. So consider seeing someone who sees a lot of PKD.
Just putting into the comments section on our website, we have a database of PKD specialists in North America. So feel free, everyone, to check out that link if you're wanting to kind of have a look at where some of these PKD specialists might be. And by all means, contact us if you have questions about that.
Can you still hear me well, Michelle?
Pardon me?
Can you still hear me well?
Yes. Yes.
Yeah, okay, my headset just cut out, so okay.
Oh.
So the next question is, what genetic studies are ongoing? Yeah, so we're learning a lot more about RNA and how to silence RNA. So in fact, we're doing a clinical trial at our center where there's a medication that you give an injection once every 6 months, and it silences the blood pressure gene, like one of the blood pressure genes. So it's like a blood pressure medication given every 6 months. There's already one out for high cholesterol, for example. So some of these RNA silencing things are being studied from PKD to possibly silence some of those genes, like 6 months at a time. And how much blood pressure? It's as many medications as you need typically to get to the target blood pressure. So focus not on the number of medications, but on the target of about 110 at home. If you are not dizzy, having a blood pressure of 100 to 110 at home is totally fine. So that's my key message. Like, try to monitor blood pressure at home, and if it's between 100 and 110 and you're not dizzy, no problem. Yes. So the next question is about SSRIs. I'm not aware of any definitive literature that would suggest that SSRI makes cysts grow faster. I think you're safe to use an SSRI if you need it. There is certainly not even mildly convincing evidence. So you should use whatever is best for your mental health. There's no one or other type of medication that's going to be safer. Yeah, potassium. So if the kidneys are working quite well, then you can eat as much potassium as you want. And potassium is often in healthy food, right? It's in tomatoes, but in lots of fruits and vegetables. Potassium restriction only comes into play in much later stages of kidney disease. So I would say if the kidneys are working good right now, eat potassium. Jillian, I think if your GFR is 11%, you may reach kidney failure before and require dialysis or a transplant. Not the research specific to PKD may not be helpful, but I think what you could be optimistic about are one, home dialysis options and machines are way better than they used to be 10 years ago, and two, many of us feel that xenotransplantation, which is transplanting pig organs, is somewhat is going to happen in the next 5 to 10 years, if not sooner than 5 to 10 years. So you may need a transplant, but that may be the last transplant you need because the medications are excellent, and it may be that if you're on the wait list may shrink rapidly if we're able to transplant animal organs. So again, I know that sometimes the world seems kind of closing in when your kidney function is 10 to 12%, but please, if you can, stay optimistic. Science is improving at a very rapid pace. And Tatiana had questions, I believe.
Yeah, Tatiana, if you want to come on again, feel free to ask your questions.
Thank you. I just want to say before I ask my couple of questions, thanks for your opening speech there about being optimistic. You give me hope. You give me hope for my kids. And so thank you for that. I have two questions, if I may. The first one, you did kind of touch base on the supplements. So I do take vitamin D. I know you kind of said no vitamin C, but what's your thoughts on taking vitamin D, especially in the winter months? That's my question one. I don't know if you want to answer that, and then we'll go to
Yeah. So I think the thing with vitamin D is that people who have low levels don't do as well as people who have normal levels. But all the studies show that when you give people with low levels vitamin D, it doesn't really improve their outcome. So I think it's more of a marker of people who can't go outside and people who stay indoors all day, rather than something that we can change. So I think it's okay. It's probably not harmful to you, but again, stay away from vitamin C. And I think the data just didn't pan out. And there was a lot of excitement about vitamin D a few years ago, and it was being tested for cancer, for heart disease, for kidney disease. Just hasn't. None of the trials have been positive.
Oh, okay. And that's why I was kind of started taking it, is because of those things you're talking about.
Yeah.
And so that's why I figured I would ask that. So that's good to know. Thank you. And then my second question is, in terms of having the most accurate kidney size, what is better, the MRI to determine that or the ultrasound? And how accurate is the ultrasound to establish that?
The ultrasound is okay. I would say it's about 70 to 80% of the way as an MRI. The MRI is the most accurate, no doubt. No doubt.
Okay.
So MRI ultrasound is about 70 to 80%. So what happens is, if somebody is like really, really large, right, or really, really small, you don't need the MRI, right? Because they're so large on ultrasound or so small on ultrasound, you don't need it. Where I would push for an MRI would be, let's say if you're on the edge, right? Like you're on the fence. It's like large, but not like just meeting the criteria, and so on. And honestly, the truth is that has to do with like the resources in our system, right? Like, and it has to do with a long wait list, where ultrasound wait list is very short. So this is why we do it this way. Yeah.
That makes sense. Thank you.
No problem.
Awesome. I have a few more questions, Dr. Tangri, that people have asked ahead of time. Are you okay to take a few of those?
Sure.
And would you like to end at 4 o'clock? Are we able to go a little bit longer or?
We can go a couple minutes longer, sure. Yeah, let's continue through the questions.
Okay. Someone had asked, they worry about their abdominal pain and they want to know how can they tell that the pain that they're experiencing is from their liver or kidneys and not something else like cancer.
Very, very difficult to say. So the only thing I can describe is that the pain, the classic pain, so everybody perceives pain differently. The classic polycystic kidney disease pain is a dull ache that responds to like a hot water bottle or like you want to kind of press on it. It's not like a sharp stabbing pain typically, unless it's a cyst rupture. But everyone just perceives it differently. And so I think this is not like, I can't say much more than that.
After a kidney transplant, will cysts grow on a new kidney?
No, not on the new kidney, but the cysts, if you have your old kidney, if it's still in you, may continue to grow.
Are there any ways to project how long an individual, how many years it may take for their kidneys to decline?
Yes.
Okay.
Yes. So please work with your doctor. Ask them to look up the Mayo Clinic tool. There's a Mayo Clinic Calculator, which helps you project at least 10 years out what your kidney function is going to be like. Projections are not perfect, remember, but it gets you a starting point.
Awesome. Is there a cutoff age for kidney transplant?
It's getting later and later. There's no specific age, and whatever the age you would think is getting later and later.
Are you still okay, or do you need to leave?
Yeah, I just got a phone call, but that's okay.
Okay. Is kidney replacement possible if you have PKD and IgA nephropathy?
Yes, you could still get a transplant. IgA may recur in the kidney, but that's okay. We still transplant lots of IgA nephropathy. Sometimes it doesn't recur. And then PKD does not recur. Like you don't get cysts in the new kidney.
Right. For someone who has numerous cysts on a liver, how often should they get an ultrasound to keep track of how it's doing?
I think, sure, for me, let me just, I keep track, I would say you got to have a reason why you want to keep track. So that's my general rule, right? Like, I don't like to do tests unless I'm going to do something with that information. So that's the key for me. It's like, if you're contemplating a procedure, if you're contemplating something else, then maybe, but otherwise, I think tracking for the sake of tracking, I'm not sure,
For someone born in a body with a uterus, and they're going through menopause, how does estrogen affect either PKD or PLD? Is it safe to take? And if it's not, what kind of things could be taken to help with things like hot flashes?
So I think that's a question that I would want to look up, because I know there's some literature, but I don't know it so well that I want to give an answer, and I don't want to lead someone astray on that, because I think those are important symptoms, and I would want to look that up and read about it before I could give an answer.
Would it be good advice for them to go to their own nephrologist?
They should go to their own nephrologist, particularly if they see someone who treats a lot of polycystic. That person would know.
So, is there a conclusive test that diagnoses PKD? Or
sorry, go ahead. Or
how do they know if they have PKD1 or PKD2?
Genetic testing, which is very conclusive, can tell you between PKD1 and PKD2. Genetic testing can find more than 95% of the genes that are responsible easily. And then the diagnosis can also be made clinically based on your ultrasound or your MRI or your CT scan. There's a fairly characteristic visual of the kidneys that only exists in ADPKD typically. Yeah.
Sure. So I often hear questions from patients who are kind of in the kind of stage 3, and so their eGFR is under 60, but not too low, and they're wondering what those numbers mean. What does it mean when their eGFR gets to 25 or 20 or 11?
Yeah, so they can think of it as we all start with about 100% of kidney function. If their kidney function is, so remember, our organs are very smart. So we don't feel symptoms till you get to from kidney disease until we lose 70% of our kidney function. Typically, most people don't have any symptoms till kidney function is below 30. But you have lost. If your kidney function's 40, you've lost 60% of your kidney function. So this is where those calculators like the Mayo Calculator can be really helpful. You can plug in where you are today, and it can try to show you based on your kidney size what your kidney function would be in 10 years.
And the last question I have that people had sent in ahead of time was, what are the chances that I won't have to have a transplant? And I realize that's probably a little open-ended or vague.
Yeah, I mean, let's put it this way. If no one in your family with polycystic kidney disease, you had family members who had polycystic kidney disease and none ever required a dialysis or transplant, chances are pretty good you won't require a dialysis or transplant. Okay, it's not a guarantee, as you know, right? Because you can have kidney disease and diabetes, you can have a bunch of stones, you can have a different trajectory, but yes, chances are no. If everyone in your family who had polycystic required dialysis or transplant, again, chances are that you will also. Now, can you push it out 5, 10, 15, even 20 years? Yes, all of that is possible. Your fate is not sealed, okay? That's the key message, that your fate may follow what your family member has, what your family members have. But if you think about medical science, if you are doing all the right things and medications are improving, it's almost certainly going to be better, not worse.
Okay, and I see there's one more question that's popped up in the Q&A.
Yeah.
Someone is asking if the cysts continue to grow, if after a transplant or dialysis you still have your old kidneys, would people continue to take tolvaptan?
So I think it has to do with the risk benefit. So when you take it before transplant or dialysis, you're preventing transplant or you're slowing down the progression to transplant or dialysis, right? And tolvaptan is not an easy treatment to take per se. So the risk benefit doesn't weigh as well once you're already on dialysis or transplant. And remember, it doesn't stop cysts from growing. Cysts grow about 20 to 30% slower. So your cysts will still grow, and this is why we stop it when people get to dialysis or transplant.
Awesome. Well, someone else has said, thank you for answering that question. Awesome. I believe that's all of the questions, and I just want to be respectful of your time. So thank you so much, Dr. Tangri.
Yeah, and I want to thank the attendees for attending, and I think for supporting the PKD Foundation and the community. All of this research and this renaissance in PKD happens because of patient advocates and people who are passionate about the disease. And so please advocate for yourself and your family and go and seek out the best care because you deserve it.
We'll now move on to our patient story and a reminder that during the original live event, this section of the presentation was first before Dr. Tangri's presentation. Tatiana Walker is a PKD patient living in Winnipeg, Manitoba. She founded the Winnipeg chapter of the PKD Foundation of Canada. Tatiana is passionate about raising awareness and funds for PKD research so that her children may someday benefit from better treatments or a cure for PKD. This is Tatiana's story. Tatiana, welcome.
Hi, thank you.
You're welcome. We're so glad to have you here today. And part of the why we like to have patient stories in our events is so that people can hear from various people across Canada what their own journeys have been like and realize that they're not alone. We're going to start with what was the history of PKD in your family? Did you know about PKD before you were diagnosed? Were there other people in your family who had PKD?
No, so actually I've never heard of PKD before I was diagnosed. Nobody in my family had it, or at the very least, we didn't know up to that point that anybody has had it. My dad's parents died quite at the young age in a small town in Ukraine. So who knows what if they had that or not. And my mom's parents, I mean, they lived until their 80s. So when I was diagnosed with PKD, I actually went into the hospital because I had some pains on my sides and I wasn't sure what was going on and I couldn't walk. And so after 3 days and numerous emergency visits within those 3 days, they had finally admitted me and diagnosed me with PKD. And I remember when they first told me, I was like, oh, okay, I'll just take some medication and I'll be well on my way. I'll be fine. And then as the weeks progressed, I think it started to kind of hit me, okay, you know, this is not just something that's going to go away and I need to find out more about it. And as I was doing research, I was fairly shocked. I think I remained shocked with my diagnosis for probably 2 years after my diagnosis. So, yeah.
And what was it in particular that really was so shocking to you? Was it the learning about kind of the severity of PKD, or what was it that just was really shocking to you?
I think, you know, when you hear kidney disease, you automatically, you know, it sounds kind of severe, a disease in the kidneys. I think when I heard polycystic kidney disease, for I don't know what reason, it just didn't register with me, right? So, and I think because maybe around that time, because like I said, I spent 3 days going back and forth between home and emergency. Different doctors kept telling me, you're fine, like here's naproxen, like the pain's gonna go away, like everything's coming back normal, you're a healthy, you know, young 22-year-old, like go home, relax, you'll be fine, you know. So I think when I finally got diagnosed, it didn't click. I've never heard of PKD. I didn't know anybody who had PKD. I didn't know what that was all about. And even when the two doctors came in to explain to me like the PKD, like I think they tried to sort of break the news a little easier, right? They don't want to overwhelm you with these things like your kidneys might fail and you'll need a kidney transplant. Like, no, they run you down with the things you can do and how it might affect you. But I think just being in the hospital and hearing news, you're kind of like your brain just sort of shuts down. So I just think everything put together kind of added to that shock factor for me. Yeah.
What were some of your next steps in trying to learn more about PKD or learn more about what your future might be like with PKD?
Yes. Yeah. So, I mean, I didn't have any resources, right? Like I didn't know anybody who had it. I didn't know where to go. So, I mean, naturally I went to Google, right? And as a lot of people know, sometimes Google is overwhelming and scary. And so lots of research about PKD and just reading things and reading doctors' notes and such and looking at pictures and reading about family history and, you know, chances of your offspring having it being 50% and just all of that. And that's actually how I came upon the Polycystic Kidney Foundation of Canada, is through all that research. And that's why originally I had reached out to you guys, because I was like, I am alone and I need, you know, I need help and I want to hear what others have to say. I need hope. You know, at the time I only had one child and already I was thinking like, does he have it? What am I going to do? You know? So that's kind of how it all came about with me getting or volunteering for the foundation as well.
Has PKD affected your life between when you were diagnosed and the present day? Like, have you had any challenges with PKD symptoms, or has it been pretty smooth, you know, since the time of your diagnosis? Or
I feel like for the most part it's been okay. I think mentally it's been more challenging than physically. I do have kidney pains sometimes, and I am on medication to lower my blood pressure because I do have high blood pressure because of it. My kidneys are still working at 100%. They're just quite large for like where I am in my in age and stuff. So, but day to day, I'd say for the most part, I do feel okay. And I think for me, it's more of like the mental aspect of having to think about it and deal with it.
How do you cope? Is there anything specific that you do to kind of cope with either physically or mentally some of the challenges you might have with PKD, or thinking about your future or thinking about your children's future? Is there anything that you found really helpful for yourself?
You know what? To be honest with you, it kind of depends like week to week, because there's weeks where I absolutely don't want to hear anything about PKD. It just reading about it or hearing about it automatically puts me in a kind of like a depressive state about it. And there's times we're reading about it and reading other people's stories that have came through it and have kind of seen sort of the more positive things after like a transplant. Like then those days make me feel like, okay, like whatever challenges I have ahead, I can get through them. Other people have gotten through them. I can get through them. I think for me, I did decide to get all of my kids tested like quite at a young age, and they all do have the PKD as well. And I think that also adds to my mental burden of having to think about it. But we do try to just focus on being healthy, a good diet, and walking lots, and trying to fixate on things that we can control at this time, as opposed to thinking super far ahead, like, will I need a transplant in 5 or 10 years? Will my kids get to that point? I'm just trying to think, there's been so much research that's been done up to this point. There's been things that have came out that is going to help. So I'm thinking like eventually we'll get to a cure. It's kind of what helps me cope. I just think I know there will be something big for this disease. So
Right. What do you wish that you'd known when you were younger about PKD, or if you could go back and say something to your younger self or give advice to yourself when you were younger, what would you say to yourself, to your younger self?
I think I would just say, like, I just take one day at a time, and just take one day at a time and stay positive. I feel like you cannot control the outcome. You can you can eat healthy, and you can focus on the good things, and what will happen will happen. And I think just thinking one day at a time as opposed to further ahead, it's just going to help you be in the present, and kind of live happier in the moment that you're living in. So
What can you expand a little bit more about what it meant to you to discover about the PKD Foundation of Canada, and either connecting with Jeff and the Robertsons, or learning about the information on our website? How did that help you in your own kind of journey and coming to terms with PKD?
well, I think it made me realize that I'm not alone in this, which is how I felt when I was first diagnosed, right? I felt alone and scared and well, sad. So I think just being able to have other people's stories and other people that are there and saying like, we're here for you. We have answers. We have doctors that are willing to help answer questions for patients. We are a community. That is kind of what it meant. It put me in a state where it's like, okay, I can take a breath. I'm not alone. And if I ever have questions or I need to talk to somebody about it, like, I know there's people there that I can do that with. So
Awesome. What are your sort of dreams and hopes for the future? Oh,
I'm sorry, say that again.
what are your sort of dreams and hopes for the future, whether for yourself or for your kids, or for, your children's children? What are some of the things that you hope or wish would happen with regards to PKD?
I hoped that by the time my children get to their 20s, that there's a cure. I hope that they don't have to deal with it mentally and physically. I hope that the gene ends with my children, so my children's children don't have to have it. There's lots of hopes and dreams there, So ultimately, I kind of wish that this disease would disappear, to be honest with you. I know that's a big dream, but I think, I'm optimistic about the future of it. So.
For sure. Now, you are located in Winnipeg.
Yeah.
Is there anything that you're aware of, either related to being in Winnipeg or in Manitoba, on a larger scale, that's a special need for people living in Manitoba or near Winnipeg? Have you sort of come across some changes that you wish maybe you could make to the healthcare system or access to care?
No, I think, since being diagnosed, like that's been one positive thing, is that the doctors did take it seriously and have been following me and making sure that, we are checking my kidneys on regular basis, and ultrasounds are being done and MRIs are being done. And so I feel like in terms of that part of it, the doctors have been great. I couldn't have been more grateful for the care I'm receiving up to this point. Yeah.
We have a few more minutes before Dr. Tangri will join us, and I'm wondering if anyone who is attending this event live has any questions for Tatiana that you might want to ask her. You could put something in our chat, or you could put something in the Q&A area. Okay, and I'm just getting a note from Dr. Tangri. He is going to join the call, but he's unable to be here until 2:30. So let's just continue our chat, Tatiana. And if anybody does have questions, by all means, feel free to ask them at any time. What are, and I'm just thinking, what are some of the questions about PKD that you wish you could, that are still unanswered, that you wish you could ask a nephrologist like Dr. Tangri, who will be joining us later today?
You know what? It's hard, because I feel like the hardest part about PKD is that everybody's journey is different. And in terms of where you might be in 5 or 10 or 15 years from now, it varies for everybody. And I ask my Dr. Tanger this all the time, because he's actually my doctor. But it's like, what are the chances that I won't need a kidney transplant? Like, what are the chances that my odds are B? Like that I feel like what are the chances that my kids who have this won't ever have to experience this, because even though they have it, maybe it's not going to be as severe, and maybe they can live until they're 84 and never even have to think about it. And I feel like those are the questions that they can't answer, right? Because everybody is different when it comes to this. So I'm not, I wish there was more research in terms of that. Like, yeah.
Sure. And I know that once I introduced Dr. Tangri, some of his background is in that area, in trying to predict what will happen with kidney decline, kidney disease, and potential, kidney failure. So that may be something that we can ask when he joins the call, that, what are some ways that patients can learn more about what may happen to them in the future?
Yeah. Yeah, and
Excuse
it's
me.
hard. I mean, I know there's like the GenArc available now for PKD, for some PKD patients, but even with that, it's hard to predict for them, right? Because I mean, my story, I'm speaking just on my story. It's like, they say, well, we predict maybe your kidneys will fail around 55 based on your kidney size. But perhaps if you take GenArc, your kidney, that could be maybe by 62, but we can't tell you for sure, right? It could be sooner, and then it's like, well, you're taking a medication that may or may not help you have your kidneys for longer, and it's just, I think that whole aspect of not just GenArc, but everything revolving around that is difficult.
Now, is that something that you have explored the possibility of yet? Or is that something that's sort of farther down the road in your future, if at all?
Yeah, I actually started GenArc. It was late spring of this year. And I found it quite difficult to be on it personally. I did take a little bit of a break throughout summertime. I took it for maybe like two or 3 months, and I did stop and take a break. I found it quite difficult to live life on it. I know it, reading and hearing other people's stories on it, it kind of differs for everybody, but for me, it affected my day-to-day life too much. And then that's another challenge for me. It's like, okay, well, what if I'm giving up the opportunity to have my kidneys till I'm 65? But then it's like, well, what if me taking it in my like early 30s, I'm 32 now, and suffering and not really living my life to the fullest, quote unquote, but then I'm still gonna have a transplant at 55 as if I never was on it. That is kind of the thing I've been struggling with. I still haven't decided if I'm gonna go back on it or if I'm gonna just wait and maybe try again in a couple of years, so.
And that does sound like a really tough choice, between present day quality of life and a future unknown.
Exactly.
Not knowing what the results will be. Yeah, for sure. There are some questions now. I can see someone has asked, who else do you see in addition to a nephrologist?
Nobody else.
So just your nephrologist and, your primary care team.
Exactly, yeah. I did actually try, I did want to get a second opinion in terms of the GenArc, but you have to get approval from your current doctor, and it was, so I just decided, that's okay. I wasn't gonna go do that anymore, and so, yeah, I don't see anybody else.
Now, have you thought about seeing like a nutritionist or a registered dietitian or someone else who may be able to give you some more insight into helping with your disease progression?
No, I mean, I've thought about it before, but like I said, like I do read up a lot online, and I'm quite, like, I feel like I'm, aware of what I can do in terms of eating habits and drinking habits to help preserve my kidneys. So yeah, and like I said, sometimes for me it's better for me to just not think about it, and not, like, there's weeks where I don't even want to think about it. I don't want to talk about it. I don't want to hear about it. It helps me get through that week,
Yeah. Someone else has left a comment, not so much a question, but they've just said, thanks, Tatiana, for sharing your story and making it available this way. And she says, feel less alone here. So that's a wonderful, yeah, that's a wonderful comment. I have another question, and you may not be able to answer this one, Tatiana, but we'll put it to you. they're saying, what initiatives are important to support and develop now that can help children with PKD in the next 10 or 20 years? So for fundraising, where is it important to spend the money? Are you aware of particular research that to you would seem important or anything else? And as I said, I don't know if that was necessarily directed to you, but I will let you weigh in on if you have any thoughts about where you would love to see funding go for PKD.
Well, I think my personal opinion on where I would like to see funding go on the PKD is towards a cure. So whatever that may be, right? I really, what I would love and my dream for my kids, and like I said, I have 3 of them, 12, 5, and 7 almost, is for them to not have to do this, for them to not have to think about it, for them to not have to worry about, am I gonna die? Will I get a transplant? Will my kidneys fail? Will my life, be different? Like, my son is 12. He is in love with football. He's taller than me now, at 12 years old. He's got bigger feet than I do. He loves football. And our last appointment with his kidney doctor, she said, you will never be able to play professional football. I think that was challenging. I don't think we expected to hear that. We didn't ask to hear that. We weren't going there to hear that. She just asked him what he loved doing. He said he loves football. He plays football for our home team here. I think that hit me in the moment. I almost cried, like I almost broke down, but I knew I had to stay strong for him. But to a 12-year-old to say to him, like, your dream, you can't do it ever, is hard. Right? It was hard for me to take, never mind my 12-year-old son. And so I don't want them to live that life. I don't want them for people to say, you cannot do this. Like, I want them to have the ability and opportunity to do what they want to do. So I don't know if that kind of answers it. I guess I just want a cure for them. Like,
I hear you.
Living the way I am, but just help my kids.
One more question before we go on to Dr. Tangri. Someone is asking, do you have big cysts? And if you feel like sharing that, that was one of the questions.
Yeah, I do have a couple of big cysts. Like I said, my kidneys are quite large according to my doctor, and so I mean, like I do get pains, but I'm quite grateful that it's not severe. Like I'm still able to, be a mom and be a wife and work full time and volunteer and all those kind of things. And so I just try and focus on the positives, because I think for me personally, it's the easiest way to get through life and to be supportive of my kids and be optimistic for them. So I just try to think positively and just kind of keep on moving.
The PKD Foundation of Canada would like to thank both Dr. Tangri and Tatiana Walker for their presentations at this PKD patient forum. If you have additional questions that you'd like to ask nephrologists like Dr. Tangri, feel free to email us anytime at endpkd@endpkd.ca.